Thank you, Pedro, and thank you, Samin, for inviting me again to this wonderful conference. This is a fantastic conference that I always learn tremendously in. So I'm going to talk about, and actually I had given this topic to Samin before in Miami Valves, and unfortunately he couldn't come, so I think he hit me with it back, which was to try to pick where Sapien 3 now and CoreValve Evolute best fits into our clinical practice. I don't really have any conflicts with this trial except for educational conference support, and I'm a researcher for the CoreValve trials and direct medical flow. So the the S3 valve is a major advance to the previous Edwards valves in multiple ways. The frame was changed to allow larger holes in the top so that you have easier coronary access in case you need to. The angles were changed in order to be able to compress the valve more fully and make it smaller. The valve is still a bovine pericardial valve, but it has now, besides its internal skirt, it has a second sealing skirt that was designed to decrease perivalvular leak. And it does so very well. This is a PET inner and outer skirt, but the outer skirt is the one that's really changed things. This is in the lower third of the valve. The inner skirt goes all the way up to the half of the valve. The delivery system now has been able to be decreased to 14 French for the majority of the valve sizes, from 20 to 26. And for the 29 millimeter valve, you can deliver it through a 16 French system. This has obviously helped in vascular complications and also in alternative accesses. Now, one of the wonderful things about this valve is the way that it's been designed for precise delivery. And basically has a central marker on the valve that you can very easily dial up and down at the exact delivery site. If you precisely put it at the bottom of the annulus, the valve will almost 100% deliver exactly where you want it, as long as the pacemaker is not interrupted. Now, the CoreValve Evolute is also a major design change. It's still a nickel titanium valve, a night null valve, and it's a self-expanding valve, so it has great conformability to abnormal shapes instead of a circular shape like the balloon expandable valves. The valve is also supraannular in design, not seen as well here, but basically you deploy the valve in a skirt here, but the valve itself is higher than the annulus, and this gives the largest annular sizes of any percutaneous valves to date and the lowest gradients. The new valve has altered skirts that allow a little bit safer or less trauma to the subannular area, and it also enhances sealing in the lower portion of the valve. The valve has also changed its radial strength in its lower portion so that it's more precise instead of only subannular expansion. So it has a very accurate one-to-one positioning with this new delivery system, and the major advance to this valve has been the way that the valve was changed so that it has a very ergonomic handle for very precise delivery. It has an inflow sheath that also acquires a 14 French delivery system when required. And then you saw this morning when a valve had to be recaptured a couple of times. This valve allows you to, if you're not happy with where the valve is going, you recapture it and then deploy it again. Now, there are no randomized comparative trials between these valves, and so we just have to look at registries, and then most of it has got to be a clinician's perspective of where it best belongs. Now, in vascular complications, this was a major problem in early trials. With Sapien, these have been reduced significantly in the recent Sapien 3 with the lowering of the French size delivery to 14 French. The Evolute is also low. They're both showing improved vascular complications. Perivalvular aortic insufficiency, which was one of the major Achilles heels of percutaneous aortic valves, has been decreased very significantly to less than 4%. Recent trials even less than 2% with both the S3 and also extremely low rates with the CoreValve Evolute. Post-procedure pacemaker requirements are interesting. Paradoxical problem is that this was extremely low with the early Sapien valves. This has increased a little bit with the S3, probably because the sealing skirt is pushing a little bit more in the conduction system. With more precise delivery and change in the way techniques, we think that this is lower now, probably near where the old ones were. And also with the Evolute, the frequency of pacemakers seems significantly less than it was, since you can more precisely deploy high in the, into the annulus instead of subannular. So are there situations where you should favor one valve over another? And this is totally clinician's perspective, and we'll talk about it. First of all, in retrograde approaches, all of them are the same, okay? At one point, the core valves were probably better for subclavian approach. This is now no longer the case, as you can use the 14 French S3 from the subclavian approach. Now still, the antigrade delivery of the valve can only be done with the S3 or the balloon deployable valves. This is a transapical and this is a transeptal. Transeptals that we almost never need to do anymore can still be done with an S3. Now, how about annular size equivalency? And in reality, they basically cover almost all the same annular sizes, with the exception that you can go a little lower in valvular size with the S3. Here, you can see that you can get down to 16 millimeters. And with the CoreValve, we used to think that we could go higher with the CoreValve, regular CoreValve, because there isn't a 31 millimeter CoreValve yet. There will be a 34 coming soon. But in reality, you can overexpand the S3 to even higher amounts pretty safely. And with here in this next case, here we're expanding it with an extra 4 cc's and Evolute 29. And you can see that this is a perimeter-derived 31 valve, an area-derived 750. And you can get a very good sealing in these types of cases. Now, the 34 CoreValve is coming, and that will allow us to even go higher than these. Let me see if I can go forward. Okay, now for horizontal aortas, and the last example was also a very good horizontal aorta, the flexing of the catheters for delivery with the Edwards allows you to be able to orient very, very linearly to the aorta itself. And so for angles greater than 60 degrees, I personally prefer using the S3. When it gets even more than that, definitely I would rather use an S3, as the CoreValve usually will have this type of delivery, an angled delivery, when you get a very horizontal aorta. Now, in its heavy subannular calcium, I prefer the Evolute, and this is because of the literature for rupture. And we know that balloon expandable valves and also just one-to-one type valvuloplasty has a greater risk of rupture. And so the self-deploying valves are preferred in this situation. How about valves and valves? We saw this morning a beautiful valve and valve that was complicated but turned out really nice. And there was a question as what you should use. And this is really great work from the valve and valve registry that looked at how these valves did over time. And what we're looking at here is basically post-procedural gradients of over 20 millimeters of mercury after being deployed. And one of the things that we saw is that the Edwards valves had a greater than 20 millimeter in the smaller valves. So in surgical valves that were from 20, below 20, or below 23, they had a higher frequency of high gradients than the CoreValve. Once it was over 23, they became equivalent. So basically, we favor them in the smaller valves. They're equivalent in the longer ones. The S3 still hasn't officially been approved in the US for valve and valve, although the XT has. Now, this is controversial, and different people will tell you, but there are some patients you just don't want to rapidly pace. I prefer then the CoreValve in those situations. This is a patient with severely depressed left ventricular function, that when you release the valve, you don't have to pre-dilate, and you can release it, and you want to do as little as possible in those patients. Those patients before we used to protect with tandem heart and or with balloon pumping if we didn't have tandem heart, that we didn't want to use tandem heart. But now we feel pretty comfortable in just doing a no predilation CoreValve. How about low coronary height? And this is a case where we had to do a post-implant. We had to rescue a coronary. And you can see with an impella. They're probably equivalent if the sinuses of Valsalva are large. But if the sinuses of Valsalva are small, you should probably avoid CoreValve. And even if you do use CoreValve with the large ones and you do have to do something in the coronary later, there's easier access to the coronaries with the S3. So as a final slide, if we look at the Evolut R and the S3, when do we think one should be used over the other? And basically in most situations they're equivalent. Dense subannular calcium, I prefer the Evolut. Intolerant of rapid pacing. Patients with TAVR and SAVR, if the internal diameter of the SAVR is less than 23 millimeters. And for S3, obviously antigrade approaches, very large or very small annuluses, horizontal aorta is greater than 60 degrees, and low-lying coronaries with small sinuses of Valsalva. Thank you very much.